Dear students, welcome to our lecture of child dentistry, course 5, lecture number 2. Today's topic is sagittal anomalies, distal and mesial occlusion, clinical, diagnostic and therapeutic methods. The correction of sagittal discrepancy has been considered a common goal for the patient and the orthodontist. A large proportion of clinical situation is not a single entity and is often associated with significant skeletal and dental imbalance in sagittal plane. Traditionally, orthodontic assessment and diagnosis is mainly based on angles, sagittal classification of malocclusion. Since the dentofacial abnormalities exist in sagittal, transverse, and vertical planes, contemporary orthodontic assessment and interpretation must include their understanding in all three dimensions. While studying the various abnormalities in anterior-posterior plane, it is also important to identify vertical discrepancies as their presence impact the sagittal dimension. The sagittal discrepancy essentially include class 1, class 2 and class 3 malocclusions. However, defining any one of these malocclusions is difficult because this arbitrary categorization consists of various abnormalities. In their original interpretation and understanding, these abnormalities represent the anterior-posterior relationship between the maxillary and the mandibular first permanent molars, as described by Edward Engel. Various factors play an important role in the development of sagittal discrepancies. Identifying and understanding the involvement of specific causative factors is essential in developing an effective treatment plan. Growth disturbances, tooth size, crowding or spacing of teeth, height of palate and length and width of arch are all influenced by heredity. These, in truth, significantly contribute to the development of class 2 and class 3 malocclusions. An injury to the maxilla during growth can produce retardation of growth resulting in class 3 relationship, while trauma during pregnancy or birth injury damaging the condyle and lead to class 2 relationship. Congenital defects like cleidocranial dysostosis, leading to retruded maxilla and prognatic mandible, cerebral palsy, resulting in loss of muscular coordination, Down syndrome or Mongolism, hypothyroidism, leading to undevelopment of mandible, and Pierre-Robin syndrome, resulting in micromandible, are all responsible for the development of class 2 malocclusion. Class 2 relationship is also caused by certain local factors like anomalies in number of teeth, missing teeth and supernumerary teeth, anomalies of form and position, large teeth, ectopic positions and transposition and tooth arc disproportion, spacing and crowding, abnormal pressure habits like thumb sucking and tongue thrusting significantly contribute to the development of sagittal discrepancies. In patients with nasal obstruction, tongue is held in forward position to keep the airway discrepancies. In patients with nasal obstruction, tongue is held in forward position to keep the airway patient, leading to short and constricted maxilla and young and expanded mandible. Disturbances in eruption sequence and timing can often result in occlusal interference leading to pseudo-class 3 malocclusion. Certain other factors, like extracted or missing teeth in their non-replacement, result in drifting or adjacent teeth, thereby developing a dental sagittal discrepancy. Diagnosis of sagittal discrepancies. Since sagittal discrepancies consist of various components and are often associated with abnormalities in other planes of space, their accurate diagnosis is a key element in the design of any successful treatment plan. It is essential to obtain adequate information about patient's problem through the analysis of high-quality diagnostic records in order to improve diagnostic capabilities. However, increased amount of patient data requires thorough analysis and make the process of interpretation a complex process. Therefore, a systematic approach to a diagnosis is the key to redefining treatment goals and treatment planning of various sagittal discrepancies and their resolution with appropriate treatment mechanics to ensure long-term stability. Class 2 malocclusion is a multifactorial entity caused by hereditary factors or abnormally acquired environmental factors that produce aberrations in form and function during occlusal development. Therefore, thorough diagnostic evaluations are necessary for correct identification of etiologic factors and affected anatomical structures, as well as proper treatment planning for correction of class 2 malocclusion. The dental occlusion and dental arch are not an isolated entity. Rather, they are a part of an extensive system comprising the teeth, basal bone, and other skeletal structures of the face and cranium that interact with the neuromuscular system and surrounding soft tissues. All kinds of dentoskeletal malocclusion, including class 2 types, are associated to one degree or another with the relationship of the following 6 dentoskeletal components. This is cranium and cranial base, skeletal maxilla, nasomaxillary complex, maxillary teeth and alveolar process, skeletal mandible, mandibular teeth, and alveolar process. These are independent functional units, but their interrelationship in 3 dimensions can produce several variations in the morphology of all dentoskeletal malocclusions, including class 2 forms. Of course, for any proper diagnostic aim, we use cephalometric analysis, and we discuss about the purpose of cephalometric analysis several times in our previous lectures. And of course, the proper treatment planning for dentoskeletal malocclusions cannot be established without a thorough evaluation of the interrelationships of these compartments relative to the dentition and dental occlusion. One of the goals of cephalometric analysis is to establish the relationships of these functional components in both the anterior, posterior, and vertical planes of space in order to differentiate the type of malocclusion. Some reports have indicated that the maxilla in class 2 division 1 patients was more protrusive, and the mandible was normal in size and position. Other studies found that the maxilla was in a normal position in relation to the cranial base, while the mandible was retrusive. Others found that class 2 skeletal pattern is due to both maxillary protrusion and mandibular retrusion. And to identify all of these pathologies, we have to depict the lateral cephalometric, which is taken for each patient in natural head position, while patient closes their teeth in centric occlusion and lips were in relaxed position. This is very important during taking the cephalometric. Reference lines and landmark to be analyzed, and the main reference line that we use from Steiner analysis. This is the most common uses analysis, cephalometric analysis. We take A and B angle between SNA and S and B, mandibular lengths, a line measured from condyle, to anatomic gnation. It was here. SN, MP, angle between sagittal plane and mandibular plane. Facial axis, angle between Bayesian to Bayesian. And posterior superior aspect of pterygomaxillary fissure to construct the gnation. Y-axis, angle between Frankfurt horizontal and cella to gnation. And the line measured from the anterior nasal spine to the menton. And all of this angle determine the protrusion or protrusion of maxilla or retrusion of mandible. Class 2 is a broad term designated to a set of various abnormalities that could be either simple or most complex. It is not a single clinical entity, rather it consists of various components of the craniofacial complex, having variation in size, shape and position. And in order to plan an appropriate treatment, the clinician should localize and quantify any skeletal and dental contribution, sagittal and vertical variation, and the role of abnormal function and habits to the development of class 2 malocclusion. There are many different types of class 2 patients with significant variations in skeletal, dental, and soft tissue morphology. As a clinician, it is critical to identify and locate the structures involved with the help of cephalometric analysis, which are mainly contributing to the development of class 2 malocclusion. Their understanding is essential to establish treatment goals and plan a treatment to resolve them. The first simple step is to find out whether it is dental or skeletal class 2 malocclusion. Dental class 2 malocclusion is caused by tooth migration, which may be confined to the entire arch or a segment of the arch following a missing tooth or abnormally displaced teeth. Skeletal class 2 malocclusion could be a result of prognatic maxilla and normal mandible, retrognathic mandible and normal maxilla, or a combination of both prognatic maxilla and retrognathic mandible. This is just a broad understanding of class 2 malocclusion, whether it is a dental or skeletal, and identifying the component involved. The class 2 patient should be further analyzed cephalometrically to ascertain the involvement of vertical discrepancy or whether it is purely horizontal in nature. Bjork divided class 2 malocclusions into forward and backward rotators and suggested that forward rotators are more common and easier to treat than backward rotators. Classification of class 2 malocclusion to group together cases having predominantly similar features is useful for clinicians to design a common treatment. These can be broadly classified as following horizontal types. Horizontal types, there are many variations in horizontal types of class 2 malocclusions, ranging from those having normal skeletal features but class 2 dental characteristics to distinctly different skeletal types. Type A, it is characterized by normal sagittal position of the jaws exhibiting normal skeletal profile. The maxillary dentition is protracted with normal mandibular dentition, leading to class 2 molar relationship associated with increased jet and overbite. This type of malocclusion is also called a dental class 2 malocclusion. Type 2 exhibits a mid-face prominence with a mandible of normal length. The maxilla is prognatic, while the mandible is in normal anterior-posterior relationship. Type C, it is characterized by retrognatic maxilla and mandible, but the maxillary incisors are either upright or labially tipped, and the mandibular incisors are proclined, as you see here. The patient usually exhibits smaller facial dimensions than other class 2 type, displaying a class 2 profile. Type E displays a maxillary prognatism and a normal mandible. The maxillary and mandibular incisor also proclined. Bemaxillary protrusion class 2 malocclusions are usually of horizontal type E. Type D, it shows a retrognatic skeletal profile with maxillary and mandibular retrognatism. The maxillary incisors are typically proclined, and the mandibular incisors are either upright or lingually inclined. Type F that we have here, it is a large heterogeneous group with mild skeletal class 2 tendencies. Each type F is generally considered to be milder, non-syndromal forms, or types B, C, D, or E. Another important aspect of cephalometric analysis is prediction of the growth pattern which is critical in treatment planning, especially for growing patients. Many efforts have been made to develop methods for growth prediction from cephalometric radiographs. Successful prediction is achieved when the amount and the direction of growth are predicted before early age treatment. Many treatment options are available for correction of angle class 2 malocclusions, depending on what part of the craniofacial skeleton is affected. Consequently, in the therapy planning of class 2 malocclusion cases, a differential diagnosis of sagittal and vertical jaw relations, as well as incisor positions, must be performed. Angle class 2 division 1 malocclusion. The typical patient with angle class 2 division 1 occlusion often has an increased overjet, incomplete lip closure, deep bite, mandibular retrogonatrism, and convex profile. Class 2 division 1 treatment is normally accomplished in two phases. First, the interjaw discrepancies are corrected by orthopedic forces. Subsequently, a second treatment phase is started to create optimal class 1 occlusion and alignment of teeth. In during mixed dentition, a functional appliance producing orthopedic forces can be used, and mostly we use the Anderson activator or twin blocks. Anderson activator, which was created by Anderson in 1957, one of the first functional appliances that attained extensive clinical use, is constructed to alter the functional pattern and simultaneously stimulate muscle activity that is converted to a force designed to move the teeth in all three planes of space. Thus, the mandible is moved forward for correction of class 2 malocclusion and opens the bite. In addition, a retroclination of maxillary incisors and proclination of mandibular incisors will be created to promote normal lip closure. It is often necessary to start the treatment with transversal expansion of maxilla to achieve appropriate width for the maxilla when the mandible is in advanced position. Other functional appliances for angle class 2 malocclusion correction are the Harbolt activator, Frankel function regulator, Bass appliance, and Clark's twin block. The twin block appliance was first developed by William Clark in 1977. Since then, the appliance has undergone considerable adaptation and streamlining, much of which has been promoted by the originator. Appliance encourages the mandible into a forward posture during sleep, maintaining forward position over a 24-hour period. Over the past 30 years, the twin block has become the most popular removable functional appliance in the world, mostly in Europe. Its proposed advantages include the following. Overjet reduction is typically rapid, simplicity and low cost. The appliance is relatively simple to fabricate with low associated laboratory costs. Versatility, it allows concomitant expansion, and there is ability to add headgear and to vary the design depending on vertical, skeletal, and occlusal requirements, and good patient tolerance. The twin block appliance in particular is studied to patient in the late mixed or early permanent dentition, as there are sufficient erupted teeth to anchor and retain the appliance. When the appliance is in place, it is essential that the lower block engage anterior to the upper block to maintain the forward posture of the mandible. Otherwise, the mandible may be maintained in a downward rather than forward position. The latter will fail to maintain the required forward posture necessary for class 2 correction, but may also impair the comfort of the appliance, leading to lip incompetence with the appliance in situ and ultimately risking poor patient compliance. This engagement is ensured by registering the bite open beyond the freeway space, and the general finding is that the posterior teeth are 5 mm or more out of occlusion. Functional appliances can also be combined with headgear, the aim of which to restrain the forward growth of the maxilla. The treatment choice depends on the dental alveolar and skeletal situation during early adolescence. In case with class 2 division 1 malocclusion, mandibular retrognatism and deep bite, a fixed appliance in both jaws combined with class 2 elastic can be used. The class 2 elastic support the correction of class 2 malocclusion and open bite. In even more severe class 2 division 1 malocclusion cases with mandibular retrognatism, the herpes appliance may be very useful. This appliance has been extensively described and evaluated. According to existing evidence, fixed functional appliances are effective in the short term to improve class 2 malocclusion, but the effect is mainly dental alveolar rather than skeletal. If proclined maxillary incisors are evident because of mesial drift of the lateral segments and with normal skeletal relationship between the jaws, extraction of 2 maxillary premolars and fixed appliances in both jaws can correct the increased overjet and establish a stable occlusion with class 1 relation between the canines and class 2 relation between the molar. Treatment of adults, if adults has severe mandibular deficiency, retrognatism, we have to combine it orthodontic and surgical correction. A common orthodontic surgery procedure for setting forward the mandible is sagittal split. In surgery cases, the risk of surgery should be within acceptable levels and the benefits of surgical treatment should be obvious. However, some adult patients refuse combined orthodontic and surgical corrections. Instead, a non-surgical correction of the class 2 malocclusion is performed by dental camouflage to mask the skeletal discrepancy. The correction consists of bilateral extraction of maxillary premolars to give the possibilities to retract and retrocline the maxillary anterior dentition to achieve acceptable overjet and improved smile aesthetics. Even if the camouflage treatment is compromised treatment, satisfactory results can be achieved with a functional occlusion and acceptable facial profile. Let's see here. A clinical case. 11-year-old female presented with a class 2 division 1 malocclusion on a moderate skeletal class 2 pattern with reduced vertical dimensions complicated by an increased overjet about 11 millimeters, increased overbite, generalized spacing, and maxillary proclination. During treatment plan, we modified twin block functional appliances with sectional lower fixed appliance, and before preparing the twin block, we have to take the functional bite, because the acrylic should be 2 mm thick anteriorly and has grooved upper and lower surfaces. Here we put maxillary incisors to sit into one of the 3 upper grooves to control the amount of mandibular advancement. The mandibular incisors fit into the single groove on the lower surface. The anterior thickness of 2 mm should control the vertical opening anteriorly, resulting in well-tolerated and comfortable appliance. In this instance, full sitting was not achieved anteriorly, resulting in a corresponding increase in the height in the premolar region. A further record is shown with full sitting anteriorly, corresponding to a minimal opening. The wax thickness is greatest in the premolar region before reducing in the molar region, reflecting the orientation and depth of the occlusal curve. Like here. After modifying twin block, upper and lower pre-adjusted edgewise appliances used, and here we have long-term retention, the final result of treatment here in the picture. And the etiology of this malocclusion, for instance, was multifactorial. The moderate skeletal class 2 discrepancy resulted in an increased overjet and class 2 molar relationship. The overjet was exacerbated by the presence of lower lip trap. The generalized spacing was a result of an underlying dentoalveolar disproportion. This was compounded by bimaxillary proclination, which aroused due to the resting soft tissue pressure and dentoalveolar compensation. Why was a lower fixed appliances placed in conjunction with the functional appliances? Because we want to correct the inclination of mandibular incisors to facilitate optimum skeletal changes with functional appliance therapy and consolidation of lower arch space. Angle class 2 division to malocclusion treatment can be undertaken easier in the mixed or in the permanent dentition. Since the malocclusion is associated with retro-inclined maxillary central incisors and often at least one proclined lateral incisors and deep bite, the treatment is usually achieved in 3 phases. The treatment starts with proclination of the incisors. The class 2 division 2 malocclusion is converted to a class 2 division 1 malocclusion. The proclination can be performed either with palatal springs in removable appliances, or the incisors can be pried in a full fixed appliance. In the second phase, the mandible is advanced in bite opening performed by removable or fixed functional appliance. And finally, in the third phase, a multi-bracket fixed appliances is inserted in both jaws in combination with class 2 elastic to create an optimal class 1 occlusion and alignment of this. In severe skeletal class 2 division 2 malocclusion cases in adults, treatment will start by orthodontic proclination of the maxillary incisors and will often be similar to treatment of severe cases of class 2 division 1. Combined orthodontic and surgical correction. Class 3 malocclusion. Class 3 malocclusion generally manifests at an early age, and it is one of the difficult clinical situations to treat. The factors responsible for development of class 3 malocclusion are different from those in class 2 situation. As compared to class 2 relationships, most class 3 problems have a strong hereditary component. Environmental influences like habits and mouth breathing also play an important role in the development of class 3 malocclusion. A growth stimulus from the constant distraction of the mandibular condyle in patients with abnormal mandibular posture can result in excessive mandibular growth. Class 3 malrelationships are often associated with morphologic and functional consequences. Patients with class 3 problems may present with an impairment of dentofacial aesthetics and occasionally with psychological issues. This clinical situation may lead to incorrect loading of the teeth. Chewing and speech function may be altered. The prosthetic rehabilitation of the case may be difficult. Like class 2 malocclusion, class 3 malocclusion is not a single clinical entity. Rather, it consists of various components of dentofacial complex. In a broader perspective, it is generally considered to be a manifestation of mandibular prognatism or mid-face discrepancy, deficiency, or a functional forward shift of the mandible on closure to occlusion. Therefore, it could be skeletal class 3, dental class 3, or pseudo class 3, all resulting from a variety of combination. It is critical for the orthodontic professional to localize the disharmonious elements contributing to the class 3 malocclusion. Other affected areas in the dentoalveolar complex of individuals having class 3 malocclusions also include larger mandibular plane angles, larger gonial angles, longer mandibles, and compensation of the dentition with maxillary dentoalveolar protrusion and mandibular dentoalveolar retrusion. While evaluating the class 3 relationships, it is important to identify whether the problem is dental, caused by the improper inclination of the maxillary and mandibular incisor, functional, caused by occlusal interferences, or skeletal, caused by the discrepancies of the maxilla and mandible. Therefore, the evaluation of a patient with class 3 morphology should have a prescribed protocol to include assessment of general facial morphology, identification of abnormal components, the vertical position of the mandible in posture and occlusion, and the position and angulation of the maxillary and mandibular incisor. It is important to follow a well-organized and systematic approach to the diagnosis of patients with class 3 malocclusion to determine the following variation in the class 3 skeletal profile. It is essential to assess the position and angulation of maxillary and mandibular incisors and the resultant interincisal relationship. The class 3 relationship may be associated with an edge-to-edge relationship, a negative overjet or positive overjet. If it is associated with negative overjet, like here in this video, if it is associated with negative overjet, the clinician should proceed to functional assessment to differentiate between true and pseudo class 3 occlusion. If class 3 molar relationship is associated with a positive overjet or like here, edge-to-edge contact, edge-to-edge incisor relationship, a compensated class 3 occlusion is suspected. A compensated class 3 occlusion is a clinical situation where the maxillary and mandibular incisors compensate for the existing skeletal class 3 discrepancy. When you encounter a patient with anterior crossbite, it is easy to assume that patient has a class 3 skeletal tendency, but if you observe that their upper anterior teeth are retro inclined, patient may be in fact not be class 3. Occasionally, the lower anterior teeth loss of flare facially, they collide with the upper anterior teeth. It is important to evaluate this patient with their lower teeth out of occlusion, with their lower jaw retracted posteriorly as far as be comfortable. Then patient close another point of contact. If you notice the patient incisors contact to end to end, the patient may in fact be actively protruding his mandible to slide past this interference. This allows the posterior teeth to come into occlusion by bringing his upper anterior teeth forward into ideal alignment and retracting displayed lower anterior teeth. You may unlock the patient's natural bite. With this interference now eliminated, you may allow them to close in a more ideal position. Cephalometric analysis is a valuable diagnostic tool that drives the clinician to pinpoint the components responsible for the development of class 3 occlusion. While analyzing the anterior-posterior relationship of maxilla and maxillary incisors and mandible and mandibular incisors, it is important to assess the vertical and transverse discrepancies associated with class 3 occlusion. The traditional approach to analyze patients with class 3 occlusion is to use A and B discrepancy. A and B discrepancy, this is the relationship between the position in sagittal plane of maxilla and mandible. The patients with skeletal class 3 occlusion usually exhibit negative A and B angle, with a smaller SNR, less than 82 degrees, and a larger SNB angle, more than 82. However, individual variation in cranial base, flexure, and anterior-posterior displacement of nasion often alter the A and B discrepancy. Therefore, alternative cephalometric measurements and analysis like width appraisal, effective maxillary and mandibular lengths, and nasion perpendicular to A point can be used to assess the anterior-posterior relationship of the maxilla and mandible. Treatment in Mixed dentition. Various treatment options are available for class 3 occlusion of dental origin, like pseudo class 3 or anterior crossbite with functional shift. In the mixed dentition, a common method is to use a removable appliance. This appliance consists of an acrylic plate with protruding springs or protruding screws for the maxillary incisor, with or without bilateral occlusal coverage of the posterior teeth. An additional labial bow for the mandibular incisors may also be incorporated into the acrylic plate in order to recline the mandibular incisors and to make it more difficult, like here, for the patient to achieve another shift of the mandible during treatment. Frankel 3 appliance is composed of a system of oral screens which lie in the vestibule of the mouth. Free of direct contact with the dentoalveolar systems. As described by Dr. Frankel, the action of the appliance is to influence arch development by changing the pressure created by surrounding soft tissue. It has proven effective as a primary treatment appliance in class 3 patients with mild, moderate, or severe dentoalveolar, skeletal, and neuromuscular imbalances affecting the skeletal, the dentoalveolar, and the soft tissue component simultaneously. A patient compliance with the Frankel 3 is typically quite high. It improves the soft tissue profile of the patient with maxillary skeletal retrusion. The purpose of the vestibular shields and upper labial pads are to counteract the forces of the surrounding musculature that tend to restrict forward maxillary skeletal development and cause a retrusion of the maxillary anteriors. The vestibular shields need to be positioned away from the alveolar process of the maxilla. Like here, it should be away from the maxillary process, but must fit closely the tissue of the mandible here. This results in stimulation of maxillary alveolar development and restriction of mandibular alveolar development. Because of the importance of growth to success of the Frankel technique, best results are obtained before the permanent bicuspids and cuspids come into position. Young patients seem to tolerate the appliance very well, allowing treatment to be started at a very early age, even in 5-6 years old. A fixed appliance can also be used and consists of varying numbers of brackets and wires of different dimensions and materials, sometimes with loops and bends. Another variation is a so-called 2-4 appliance comprising bands on the maxillary first molars, permanent molars, and brackets on the 4 maxillary incisors. It was concluded that both removable and fixed appliances presented high success rates, demonstrated good long-term stability, and were well accepted by the patients. Treatment in early adolescence. In permanent dentition, fixed appliances with class 3 elastic can be used. Here, fixed appliances with class 3 elastics. Often the elastic are hooked between the maxillary molar teeth and the mandibular anterior teeth, resulting in anterior pull of maxilla and distal pull over the mandible. The reverse pull headgear is a very important part of orthodontic treatment. A reverse pull headgear will help to improve upper jaw, move upper jaw forward with growth, which is critical to do at a young age. Thereby, will help to move upper jaw forward with growth, which is critical to do at a young age, thereby reducing or possibly eliminating the need for very involved jaw surgery later in life. This treatment is to be taken very seriously and followed precisely if an acceptable result is to be achieved. If crowding is also evident, the treatment can be combined with extraction of the first mandibular premolars and second maxillary premolars, or first or second maxillary premolars, but this only permits mild class 3 discrepancy to be camouflaged by tooth movements. Treatment in mixed dentition cases. Subject with mandibular prognatism, the treatment aims to restrain the mandibular forward growth. Like here you see the use of the, in this slide we see the use of the reverse headgear. And it's very important for us to use this headgear in early dentition, mixed dentition stage, or in early permanent dentition stage. It stimulates the maxilla, the growth of retrognatic maxilla, and it can be fixed to rapid palatal expander, like you see here. This is combination of the maxillary fixed appliance and and headgear. And also we use chin cup in early mixed dentition stage. This one is inhibit the growth of mandibular, the anterior growth of mandibular jaw. This is high pull face mask. Treatment of adults in adult cases of severe skeletal class 3 malocclusion, the predominant recommended treatment method should consist of bimaxillary fixed appliances technique and orthognathic surgery in maxilla and mandible. The most common orthognathic surgery procedure in the maxilla is forward movement with the Lefort 1 osteotomy, and in the mandible, easier sagittal split or Rams osteotomy is used to set back the mandible. Treatment prognosis. Treatment prognosis factors reported to influence successful treatment of angle class 3 malocclusion include the age at which the appliance is inserted, the severity of malocclusions, and the heredity. Furthermore, if the patient can achieve an edge-to-edge incisor position, it may improve the prognosis for orthodontic correction. Less favorable factors for orthodontic treatment alone include mandibular prognatism with large negative A and B angle, large gonian angle, small cranial base angle, and retroclined mandibular incisors. Long-term stability, especially for early treatment of class 3 malocclusion of skeletal region, can be difficult to predict. In many cases, early treatment may be successful and normal occlusion can be achieved. However, it should be remembered that the mandibular growth continues after maxillary growth has ceased, which implies an obvious risk for relapse of a previously corrected class 3 malocclusion. And during every treatment, at the end of treating planning, the orthodontist should have a list of treatment aims and the strategy for their achievement. There are often several options available for any given malocclusion, including no treatment, and factors that may limit what can theoretically be achieved for any given patient should also be considered. And during treatment class 2 or class 3 malocclusions, sagittal malocclusions, we have considered everything like medical health, certain medical condition, dental health, even the condition of oral hygiene, absence of active dental disease, and the most important things, you should know what your patients want from your treatment, whether it is functional problems or aesthetical problems. And cooperation with your patients is very, very important during orthodontic treatments, because sagittal anomalies, it's very dependent on the growth pattern of the patient. And thank you for today. For today, our lecture is over, and thank you for listening. I hope to see you next time.